for you. There's a bottle of water here if you need it.
Thank you so much for that very kind invitation. Thank you to all of you for coming. See if I can figure out how to work this thing. Hit that? Oh, this thing, okay. So it's my pleasure today to talk to you about moving beyond BMI as a definition, only the sole determinant of the definition of obesity. And I thank, by the way, the organizers for inviting me to speak here in beautiful Anchorage. This is what I'm going to tell you about is the fruits of a long labor from something called the Lancet Global Obesity Commission. So the journal Lancet, once in a while, gathers experts from around the world in some subject or another and says, guys, ladies, come up with some policy statements on this topic. So examples of things that have done, they're usually big categories like women's health or health of underserved peoples. So like a long time ago, 5 years ago, Lancet reached out to a handful of us and said, we need to come up with some policies regarding obesity. And I was one of the few that they started, and that later turned into the Lancet Obesity Commission. So we were charged with many things, but the most important thing we were asked to do is define obesity. Now, you know, to most of us, when we can look at somebody and so that person is or isn't, you know, suffering from obesity, but the actual definition of it medically and what matters in terms of getting insurance compensation for various treatments and remedies has been an incredibly thorny issue for my whole career. Traditionally, it's just based on a number, your body mass index, which is kind of your weight normalized for your height, and above a certain number you got it, and below it you're not. But as I will point out, that has a lot of flaws, and everybody's known that, but nobody's been able to come up with a viable alternative that can be practically used at the base level. So that's what we had, struggled to try to do. So that small core of people that Lancet reached out to then built a larger consortium called the Commission. It had, in the end, 58 members that lasted the 3 years we worked together. This is a map of the United States showing where our commissioners came from. The, kind of red dots are the countries they came from. You can see it's scattered around the world. And then the blue dots are places from which various organizations have formally endorsed our final recommendations. So these are organizations that represent obesity or endocrine societies or diabetes societies or health societies, patient advocate groups, other policy things. There are about 90 total organizations that have formally endorsed our work. This map is interesting. So every time a Lancet Commission finishes its work, it publishes its main paper, and there's a launch event. It always occurs in London because that's where the Lancet is based. Ours was in London earlier this year, and we had concomitant smaller events in each of the other continents. That map shows the countries from which journalists registered and attended our launch event. And I'm amazed. It's 92 countries, and to be honest, they include a lot of countries I would have thought had better things to worry about. I mean, more pressing things to worry about, like Ukraine and Israel and Iran and Iraq. To me, this was a kind of an academic exercise, and I would have thought they had more pressing issues, but it seems to me the world is very intrigued with what we did. And they say that the media attention to our launch was the biggest they've seen in any commission yet. So this is the title of our main paper. It is a ponderous tome. It's got 58 authors there. So I'm the second author because I was sort of the second in command throughout the process. The first author, Francesco Rubino, hats off to him, first of all. He's by far the driver of the whole thing. He's our big leader. And the paper itself is, as I said, a ponderous tome. It occupied 150 manuscript pages, that's double-spaced, and then condensed down in the actual journal to almost 50 pages. I don't think anybody's read it except maybe Francesco, myself, and the fourth author. So, but if we distill that very large thing that has a lot of content down to one sentence you had to do in an elevator going one floor, it would be this. This is my version. The Commission recommends changing the definition of obesity from simply being relatively heavy for one's height, that's BMI, to being ill from having too much body fat. And I will elaborate on what that means in this talk. So this is traditionally the way obesity has been defined. by BMI alone. And if you're above a certain number, let's say you're Caucasian, that the number would be 30, you have obesity, and if you're below it, you don't, period. Now, there are some differences depending on racial background, but regardless of the population, it's just a single number, yes or no. The Commission, as much as BMI has its flaws that I will articulate, did not throw BMI out. We think it's a useful tool, at the very least for epidemiologic studies, and also for identifying individuals who are at risk for potentially having the diagnosis of obesity as a disease. Some of its flaws, however, are that it is not a direct measure of body fat. It doesn't tell you anything about where the fat is distributed, and that makes a big difference in terms of how much harm it does, whether it's in your belly or your butt. And it doesn't determine whether the fat is causing any health problems right here and now, any illnesses. So I'll give you some examples where BMI falls apart. I'm just going to give 3 artificial cases. We'll call him Mike. I named him Mike because he reminds me of Mike Tyson, the famous boxer. So in his prime, Mike Tyson had a BMI of about 33. Now, that was when he was the world champion of heavyweight boxing. And by the definition based on obesity, he would be deemed obese because his BMI is over 30. But nobody would think Mike Tyson in his prime had obesity. He didn't have any extra body fat. He had certainly no illness because of that. So there's an example where the system is flawed. Mike was just a ripping bunch of muscle packaged into a not very tall person. So that gave him a high BMI. Here's another flaw. Let's call her Sarah. Now, Sarah does have extra body fat. She's got some rolls in her belly, in her buttocks, in her thighs, but she is pretty healthy. She runs 5 times a day, sorry, not 5 times a day, 5 times a week, runs 5 times a week. Every once in a while, she runs marathons, and there's absolutely no illness associated with her extra adipose tissue, yet she does have excess adipose tissue. The system in the past would have deemed her also to have obesity and therefore potentially have access to health care for really expensive things like tirzepatide and, deprive that from somebody else who's sicker. Because her BMI happens to be over 30. Here's another error. Let's call him Frank. Frank is sick because of extra adiposity. He has a less BMI than Sarah. His BMI is only 28 because he's kind of tall, but he's got extra fat, and it's predominantly located in his belly, and he's sick because of it. So he can't get up a flight of stairs without having to stop to breathe. He's got sleep apnea. He's got fatty liver disease. He's got joint problems. He's got a lot of problems as a result of extra adipose tissue, and yet the old system would not deem him to have a disease called obesity. Therefore, he wouldn't qualify for any insurance coverage for any interventions. So those are just 3 examples of where the system fails. In a nutshell, BMI as a standalone criteria to define obesity often either underdiagnoses or overdiagnoses the condition, leading to unfair allocation of limited resources. So this is how we tried to fix that. That's a really small thing at the top, but it says elevated BMI. So as a screening tool, we say BMI is a good starting point. If somebody's got a BMI of 20, they probably don't have to worry about this. And if they've got a BMI of 50, that's pretty obvious. It's somewhere in the middle where you'd say, okay, if he's got an elevated BMI, we then have to see if this is associated with a disease and whether it's associated with adipose tissue, extra adipose tissue. So we asked for the providers to do 2 extra things beyond BMI. The first is to use some other metric to confirm whether that high BMI is because of extra adipose tissue. So that would be the use of some anthropometric measure or a direct fancy measure of body fat content if you've got access to it, like a DEXA. So the anthropometric measures we talked about were here, waist circumference, waist to hip ratio, or waist to height ratio. And as a body of 58 people from all around the world, we argued for a long time about which of those is better and found that there are actually really, really entrenched thoughts about that depending on where you come from. In the end, we decided not to get into the weeds and argue one country versus another because there are large regional sort of viewpoints on that. But just to say, use whichever one in your country you use, but use 2 of those as standalone criteria to define obesity, and for each there are certain thresholds that define too much, or one of those in combination for BMI. Or up in the upper right corner, it says direct measurement of body fat. That would be like a DEXA. And if you have access to DEXA, that can stand alone to define extra adipose tissue. The trouble is, as a policy thing, that does not help us in some rural place in Zimbabwe. So we needed to do policies that anybody can get. Once you've confirmed there is actually, so once you looked at a person with an elevated BMI and asked the question, do they have that elevated BMI because of too much body fat? If the answer is no, then you got Mike Tyson, and that's your end, you're finished. The person doesn't have obesity. If the answer is yes, this is because of extra adipose tissue, then we ask the second question. Does that adipose tissue cause illness here and now? If the answer is yes, over on the right, you've got Frank, and that we would define as clinical obesity, a new term, meaning illness here and now because of too much body fat. If the answer is yes, no illness is caused, we define that as preclinical obesity, that's Sarah. So that's a risk factor for future disease, certainly not worth ignoring, worthy of various interventions I mentioned, but maybe not worth spending a huge amount of money for semaglutide to get if you have limited resources. So the distinction of whether a person has illness or not based on body fat gets a little bit into the kind of the hardest part of our recommendations. We listed many things that could be considered to be examples of sickness here and now because of too much body fat. They affect every body organ you can see there, or the functioning of the entire organism. They, broadly speaking, they mean dysfunction of an organ because of too much body fat, or dysfunction of the whole organism. You know, can't walk properly, can't toilet or eat or dress properly. And the illness has to be because of the body fat. If they're illness because they've got rheumatoid arthritis, they're sick, but that doesn't count for defining obesity. So again, clinical obesity by our definition is a state of excess adipose tissue associated with illness here and now, and we define that as a disease warranting treatment, including with potentially aggressive and/or expensive things like bariatric surgery or GLP-1 receptor agonists. Preclinical obesity we define as a risk factor for a future disease, but not a disease in and of itself now. Not at all to be ignored. Counseling is justified, lifestyle interventions are justified, and maybe some lower tech things like the older medicines, but maybe this is not the most compelling person to spend $1,000 a month on for semaglutide. So again, getting back to that one sentence review, the Commission recommends changing the definition of obesity from simply being relatively heavy for your height to being ill because of having too much body fat. We think this offers a meaningful and ethical alternative to help optimize allocations of limited resources to prevent and treat obesity. Jana mentioned that I'm going to talk about policy. So the policy realm where I think this is the most cogent right now is this: the allocation of new incretin-based therapies that you're all hearing about. So I'm talking about semaglutide and tirzepatide and the many coming down the pipeline. So first of all, as I'm going to talk about those medicines in another talk, but I am totally a fan of these medicines. They're terrific. If there's ever a medicine in my career that's been described as a miracle drug, it's probably tirzepatide. So here's just one example, data from the SURMOUNT-1 extension trials published earlier this year in New England Journal. You see people on tirzepatide in a randomized trial maintain 23% body weight loss at 3 years, more than 3 years. And by the way, everybody in this trial had prediabetes, and 95% of them had reverted to normal glycemia by the end of the study. In other trials, if you had frank diabetes, it'll lower A1C by 2 or 2.5 points, so you go from 9 to 6.5. So the drugs are terrific for the things they were designed for, which is to help with weight loss and diabetes improvement, and with that corollary benefits on lipids and blood pressure. Beyond that, just in the last year and a half, a whole series of hard-hitting papers have come out from randomized trials published at the level of the New England Journal or something like it that have shown improvements with one or the other or both medicine on what I call harder outcomes. In the end, body weight and A1C are just surrogate endpoints. They're numbers. They don't literally impact a person's life right now. So these things are on harder endpoints. So one of them, the FLOW study, was a demonstration of reductions in major adverse kidney events. So what's that? That's stuff people care about. It's like dying of kidney disease, getting a kidney transplant, or going on dialysis. Ditto for major adverse liver events. That would be dying of liver disease, getting a liver transplant, or developing cirrhosis. Also, major reduction in sleep apnea, with a stunning reduction of the apnea-hypopnea index by 50%, the best we've seen with any drug. Reductions in clinically significant osteoarthritis, congestive heart failure demonstrated in randomized trials for each of the two drugs, and reductions in major adverse cardiovascular events, that would be heart attacks and strokes, never shown before in a clinical trial of a weight loss drug, now demonstrated in the SELECT trial for semaglutide, and just recently revealed the SURPASS cardiovascular outcomes trial has not yet been published, but showed reductions in cardiovascular outcomes from tirzepatide. So they're great drugs, and there's lots of other cool things in terms of cancer, substance and alcohol abuse, and even dementia. No surprise, their use is going crazy. So incretin-based meds are increasing by double-digit percentages every quarter. They went up by 900% just in a few years from 2019 to 23. Use of them for people without diabetes increased by 20-fold in that period of time. And they're the fastest growing drug class in history. The trouble is, they're incredibly expensive. And that should have a lot of resonance, I would think, in this particular group, where you're dealing with indigenous people that may not be the wealthiest population in the world. So the approximate cost in absolute dollars for semaglutide or tirzepatide in our country now, this is the list price, are between $900 and $1,350 per month. To put that in perspective, the cost of metabolic bariatric surgery is about $17,000 to $26,000, and for most people that's a one-time thing and you're fixed. So the bottom line is that in significantly fewer than 2 years on one of these drugs, you could have bought yourself a gastric bypass, and for most people that'd be it, you'd be fixed. That's cost in absolute dollars. How about the cost per benefit gained, often expressed as something called cost per quality adjusted life year, an arbitrary thought of a perfect year of life. So metabolic surgery as a guide point costs between $10,000 and $25,000 per quality, which is about 5 or 10 times less expensive than the usual accepted standard by our society for what's considered an affordable healthcare intervention that insurance companies will pay for. Contrast that with semaglutide or tirzepatide, which cost a stunning $1.1 million per quality, about 10 times higher than the usually accepted standard for affordable healthcare that insurance companies will pay for. I am stunned that anybody pays for this stuff. I'm totally delighted that they do, but it's kind of amazing that they do. To quote a quote from a good friend of mine, Ricardo Cohen, metabolic surgery ain't sexy anymore, but it's cheap. And that's a funny thing because we always thought that when I say metabolic surgery, it's what you might call bariatric surgery. We always thought the price was a big barrier, but now by comparison to these drugs, it's dirt cheap. And that may have relevance to your practices. Semaglutide is now the #1 drug in the United States by costs. And this leads to incredibly painful access troubles for people trying to get the medicines. We continue to have devilish supply chain troubles that are dogging us many years after they've been developed, global shortages as a result of that, and patchy insurance company coverage, no doubt, driven primarily by their large cost. Here's a list just recently published of insurance companies that have relatively recently either stopped paying for the new incretin beds or greatly restricted their access. Most importantly for me, because I work at a VA hospital, is the entire Veterans Administration nationally stopped allowing them. So we had semaglutide for a couple of years, tirzepatide for a period after that, and then they said, these guys are just too friggin' expensive, and they stopped access entirely. So for a while, I was the #1 prescriber of semaglutide in the national VA system. I put about 1,000 people on it, and now I can't put anybody on it. Also, Blue Cross Blue Shield has greatly limited their coverage, as have these other big companies. Kaiser, Alina Health, Mayo Clinic, Mass Health, so on. The list goes on. It's getting harder and harder to get insurance companies to pay for this stuff, and it's no wonder because it costs so much. This undoubtedly contributes to the stunning data on how many people who start the drugs stop them. So here's just something published recently in JAMA Open Network showing the percent of patients who are on a GLP-1 receptor agonist who continue to take it at 1 to 2 years. The blue line is people taking it for obesity, and by 1 year, already 62% of the people are off it, and by 2 years, 83% of the people are off it. Now, is that because they had lots of side effects? No. I mean, after having put 1,000 people or so on one of the other these things myself, I'd say less than 5% of people will come off it because of side effects. Is it because they used them to lose the weight and then they kept the weight off and that's all they needed? No. Lots of studies have shown they don't work if you don't take them. Here, for example, is SURMOUNT-4 demonstrating that in tirzepatide. People went on to tirzepatide, they lost the usual 21% of body weight, and then they were randomly allocated to continue tirzepatide or go to placebo, and they didn't know the difference. What happened? The folks lucky enough to stay on tirzepatide continued to lose weight, and those unlucky enough to go to placebo began to bounce back, regaining more than half their weight by the time the study ended. This and other studies like STEP 4 for semaglutide and STEP 1 extension studies have shown that by 1 year off the medicines, most of your weight that you lost will be back. All the benefits in diabetes are gone, as are benefits on blood pressure, cholesterol, and so on. The drugs don't work if you don't take them. You wouldn't expect them to. So this leads to some hard practical truths about increasing costs for these very expensive treatments that are life sentences that you have to take for life to get benefit. A recent paper published in JAMA Cardiology this year shows that more than half of Americans qualify for incretin-based medicines by their original criteria for use, which were based on BMI. What would it cost for us to treat everybody who qualifies on them? So I did that calculation using a mid-range cost in the middle of the range I just told you. And it comes out to $2.4 trillion per year. So that's too big a number to get your head around, but let me put it in perspective. $2.4 trillion a year is about 3 times what the United States spends on defense. And our lovely country spends as much on defense as the next 10 countries combined, including big ones like Russia and China and India and Brazil and all those guys put together. So the cost of semaglutide or tirzepatide for everybody who deserves it would be, or everybody who qualifies by the BMI criteria, would be 3 times that. It's about half of what we spend on all healthcare right now, and about 1/3 of our notoriously terrible historic, national debt that's been accumulating since we were founded. It's an unbearable health cost we cannot pay. The bottom line is we need a triaging system. And so it's my hope that our new definition of clinical obesity offers such an evidence-based triaging tool to help allocate limited resources to the people most in need. And it's important to note that Lilly and Novo Nordisk used to say that their drugs, semaglutide and tirzepatide, were for people with a BMI over this or that. They have struck BMI from their inclusion criteria entirely. And now they say just they're for people with obesity. And they don't tell you what obesity is. So there's an opening here for them, hopefully for insurance companies, to use our evidence-based guidance tool to define who has obesity and who doesn't, to facilitate a more rational and cost-effective way to use expensive obesity medicine treatment options versus lower intensity preventative measures. Now, don't get me wrong. If somebody just wants to lose a little weight to look better in a dress, that's a very valid thing to want. But if you have to weigh a limited resource and triage, is that as compelling as someone who's going to die this year if they don't lose weight because they need a heart transplant? So that's an obvious case. But there's a range in there of degrees of severity of illness, and it is my position that if we can't treat everybody, we should treat those who are more ill first and let the folks who are less ill try less expensive things. By the way, our formal recognition of clinical obesity as a disease, I hope, should help reduce weight stigma, a chronic problem that we suffer from in our society. I don't know if it will, but it is our hope that it will. So that's the most important thing that we tried to contribute in our long work, and I thank you for your attention. I thank all my fellow commissioners for their hard work. It was hard to corral what started out as 75, ended up as 58 people, strong opinions from around the world, but we did eventually come to a conclusion. Thank you.
Thank you.